right now. Okay. All right. So let's see, for example, can you see my screen?
Yes.
Okay, good. All right. Let's magnify a little bit. My screen a little bit wider than a usual one. Participant can now see your screen. I'm very happy that they can see it. Okay. Now, let's try it. Okay, let's try. Maybe it's too difficult. So let's try a little bit more simple tracing, such as this one. Is not so simple one, but this can be used to see whether how can we narrow down the axis. Could you say it, or could you try to interpret the axis? Because the best one, if whoever doesn't have any clue, the best one if they can try it. Okay, so please.
Is this the one from the last class?
Yes, that's it.
So
okay,
I use the method like where we look at the first lead and the IVF.
Okay.
So I can see that it's normal because they're both positive.
Okay, that's it. So this is how you start the ECG, because nobody really interested in the normal range, nobody interested in the real axis. First of all, the instrument will read out the axis immediately, and you don't need to worry about it. Maybe during the exam, maybe you can have a question, something like that, but this is why it's not so important. We want to know which are the pathological conditions. So this is why you're starting with lead number 1 and AVF. If they are both positive, fine, this is the normal range. If you do have negativity in lead number 1, so somehow I will show you later on, immediately you can say that's a pathological right deviation, and we will have a consequence of it. Now, if we do have a positivity in lead number 1, but AVF is negative, after you have to look at lead number 2. If lead number 2 is negative, immediately you can state that that's an extreme left deviation, pathological left deviation. Okay. Now, however, here there is in a normal range. So what we will do after it? First of all, if you're using this quadrant approach, when you do have a normal axis, so it's meaning between 0 and 90, let's look at lead number 1, 2, and 3. All right? And choose the biggest one. Now, you can see that lead number 2 is the biggest one. So the axis is close to, what is the axis? When we
30.
close, no, close to lead number 2. Lead number 2 is, yes. What is the axis in lead number 2? What? 0, 60, 120. Okay, that's a Einthoven triangle, the equisided triangle.
Okay.
All right, so that means 0, 60, 120. Okay, now maybe I'm turning on the paint, because this way I can somehow show it. Okay, so let's see. This is lead number 1, lead number 2, lead number 3. Okay, and you know that the axis here is 0. The axis here is 60. The axis here is 120. Okay, 120. All right. These are the regular leads. So this is lead number 1. This is lead number 2. And this is lead number 3. Okay, good. So this is clear so far, yes? All right.
Yes.
Now let's choose here the biggest one. As you see, this is lead number 2. So when I say that this is lead number 2, maybe you can see by this way as well. If it's lead number 2, that should be parallel with lead number 2. So the axis about 60 degrees. So I would say that the axis, the main electrical axis, is close to 60. Okay. However, if you had a main electrical axis that is 60, that meaning that you are equally placed from lead number 1 and lead number 3, exactly 60 degrees. So the reflection to these leads in both leads should be equal. So meaning that the if you look at the R's or the positivity, should be equal in lead number 1 and lead number 3, yes? Because you are exactly in the middle.
Yes, okay.
All right.
It's
But
understandable.
okay, if you look at, for example, you are, because the cosinus alpha is proportional to the reflection. So you are always looking at what can we have here. So if you do have a certain elongation here, you do have this kind of reflection as should be the same because you are exactly in the middle of this angle. However, as you see here, lead number 1 is bigger than lead number 3. What does it mean? It means that you are closer to lead number 1 than lead number 3. Okay, so the main electrical axis a little bit placed toward lead number 1 and subtract minus 10 degrees, doesn't matter. So you can say that about 50 degrees. Okay.
Okay, thank you.
All right. What else?
Can we ask about the last videos that you sent?
The impulse formation.
Yes.
I will go through the impulse formation. Don't worry. I give you a short, let's see, summary of the introduction, but other thing. Let's see the basic question about the heart rate and the axis. This is the first one that we have to deal with. Anybody has any question? Okay, if not, all right, that's okay, no problem. Later on, we will go through and you will understand because we are dealing with this axis and heart rate regularly. So every time we will have this kind of interpretation and you have to have, okay, let's see first the arrhythmias, okay, so the impulse formation abnormalities. This is what we want to, and I want to summarize. This is the impulse formation. Okay, now, first of all, when we want to see what arrhythmia is, arrhythmia, first of all, is a general talking, means everything as that is not a normal sinus rhythm. That's it. Everything. It can be arrhythmic based on that the RR intervals not equally placed. That can be arrhythmia. Or can be arrhythmia that the rate is different one. Can be arrhythmia if the impulse formation is not originated from the same area that we should, so it's not in the sinus rhythm. Okay. Now, first of all right, this you can go. How do we know that, first of all, what the normal sinus rhythm is? Okay, let's see. First of all, what is a normal sinus rhythm? It's meaning that every impulse is made by the sinus, okay, by the sinus node, and the impulse is propagated from this portion to the other area of the atrium and later on the ventricle. So we do have a left to right atrial activation wave. What does it mean? It's meaning that in AVR, we do have negativity of the P wave, and we do have, I think we do have something like this, hopefully. Come on. It doesn't want to go. Yes. So we do have a negative P wave and a positive in lead number 2, and in front of the QRS complex, as you see here. And when you look at this morphology of this P wave within one lead, it should be the same because it's always coming from the same area. So the morphology should be the same. This is one thing. And every P should be followed by a QRS complex. This is another thing. And another one, of course, if you look at the heart rate, that should be the normal range. So we say between 60 and 100. If you have less than 60, that's not rhythmic. If you do have more than 100, it's not rhythmic. Of course, it's an active arrhythmia that's called bradycardia or tachycardia. All right, now let's move on a little bit. So when we do have this impulse formation abnormalities, because what can cause arrhythmia? The arrhythmia can be due to an impulse formation abnormality, meaning that the impulse form faster, or the impulse form slower, or the impulse doesn't form in a normal area. This is one thing. Or we do have a normal impulse formation. However, the impulse is not propagated normally to the compartments. This is another thing. Let's see first, and today we are discussing the impulse formation abnormalities. The impulse formation abnormalities based on the rate can be faster or can be slower. So when we do have a normal sinus rhythm, if it's faster or when it's coming a little bit earlier, this is called active arrhythmias, because that makes the heart rate faster. When we do have a slower rate, that the impulse comes later, that's called passive arrhythmias, because the heart rate is slowing down. Okay, now this is the easiest, let's see, active arrhythmia, and this is what is called premature beat. That's an early coming beat, that's a premature beat, that's it. Always you see that comes earlier. So this beat comes earlier than a normal sinus beat and followed by a longer interval. That means we do have a compensatory pause. Good. In another way, when it comes later, this is an escape beat that comes later. And of course, this will slow down the heart rate. If we do have more than 3 beats in a row, that's called rhythm. If we do have, let's say, an escape beat that coming so consequently and more than 3, that's called escape rhythm. When we do have more than 3 early coming beats, that's called paroxysmal tachycardia, for example, that later on we are discussing. Okay, you learn in physiology that there are different types of premature beats based on the compensatory pause. What does it mean? If you summarize the coupling time and the compensatory period, that gives you a result. And if that, let's see, time shorter than 2 hours, the 2 normal bits interval, that means undercompensated. If this kind of compensatory pause elongates, let's say, the bit to the same as twice as the R, that means compensated premature bit. When we do have a slowdown, that means overcompensated. Okay, so what does it mean, overcompensated, undercompensated, and compensated? Why is so important? Because this recovery period that we do have here, that's called the compensatory pause, it will be influenced, first of all, one thing, where this impulse is formed, where this extra impulse is formed. If it's formed supraventrically, meaning formed in the atrium or the AV junction, it's always undercompensated, always undercompensated. If it's formed in the ventricle, that should be compensated. However, if you do have a overcompensated or compensated supraventricular beat, that's pathological, because it's meaning that the heart is ischemic and the muscle for the recovery needs more time. The sinus needs more time to recover, to be recovered. And this is why that can be the sign of an ischemic heart diseases. So this is why it's important to see whether a premature beat is compensated or under or overcompensated. All right. Now, there is another type of bit that exactly plays between two normal bits, and that's made the interpolated premature bit. Sometimes, usually, is happening, for example, in a ventricle premature bits, when it's interpolated between two normal QRS complexes. Now, there is another possibility that this kind of premature bits comes regularly. If every second beat is a premature beat, this is what we called as a bigeminy. If every third one, that's called trigeminy. Every, let's see, the fourth one, that's called quadrageminy. This is allorhythm. Allorhythm, meaning that is it's a regular arrhythmia. because it's arrhythmic one, but regularly coming one. Okay. Now, let's see another one. Still, we are talking about active arrhythmias. So far, we had only one premature beat. But what will happen if we do have two or more premature beats that coming in a row? For example, when we have two premature beats in a row, that's called couplets. We can have triplets or salves. As you see here, the rate is starting to be faster. And if you do have more than 3 premature beats in a row and start suddenly and or ending suddenly, that is called paroxysmal tachycardia, because an active arrhythmia is always tachycardia. All right. Now, the matter of the rate of this tachycardia can be paroxysmal, as you see here, for example, in the atrium, that when the rate is around 150 to 250, that's we call it as a paroxysmal tachycardia. If the rate of the atrium is over, for example, 250 and 350, that is called flutter. And later on, it's over, that's called fibrillation. Now, what does it mean? If you think a little bit, the electrical activation and the mechanical, let's see, work is a little bit different. The mechanically, the heart is slower. You need time when the whole muscle is contracting and pushing out the blood from the ventricles. So when you do have a tachycardia, you do have a contraction, a relaxation. Normally, after you have a little gap in a relaxed phase before the next contraction starting. So the heart a little bit relaxing. However, if the rate is increases, usually this, let's see, resting period is getting closer. So the end of the T wave and the P wave is getting closer to each other. So the heart cannot rest as long as they could. Of course, it's not good. This is why they are not tolerating too much, because the heart is using a lot of energy. Now, however, they still can contract. When you reach the period when the contraction relaxation continuously coming, looks like there is no gap between the relaxation and contraction, because let's say contracting, relaxing, looks like that's a flutter, because it's fluttering of the heart. We still have active contraction, but for sure, there is no relaxation, no resting for the heart. So that's be very dangerous situation later on. However, if you increase the rate of the electrical activation, there is no time for an active mechanical contraction. And what the, let's see, the muscle does, shivering. So there's no output. So if you do have in an atrium, fine. What you do have, the atrium won't contract. So the atrium does not push through this with the active contraction any blood into the ventricle. If you do have a ventricular fibrillation, that's the worst situation, because what will happen? Cardiac output is zero. So the patient does not get any circulation. So usually is losing consciousness and laying down. Okay, so these are basically the different types of active arrhythmias when we do have an increase of the rate. So the matter of the rate we can call as a premature beat, couplet, triplet, paroxysmal one. There is another one, this is called a sustained tachycardia. Usually the sustained tachycardia is not as fast as a paroxysmal tachycardia, and it lasts longer than 30 seconds. So the rate is not as high, but it will last longer. So the patient suffering a little bit longer than a paroxysm. And usually in a paroxysmal one, sometimes the patient can stop. Let's see this paroxysmal tachycardia, because you learned in the lecture that paroxysmal tachycardia, the pathomechanism is based on the re-entry phenomenon when we do have two parallel pathways with different refractor periods, and that's all. So this is how the circus viciosus can develop. Okay, good. Now, let's go on and let's see. So far we had the different types of impulse formation based on time. So whether it's coming earlier or coming later. Now because that can be seen very nicely on the ECG, because if you do see that R equal, fine, you know that this is rhythmic one. However, if you do see that sometimes is, let's see, the place the RR interval is okay, but sometimes you do see a narrow RR interval, that's a premature beat. And if you do have faster than 100, for sure, that's a tachycardia. If you do see the beginning of the tachycardia or the end of tachycardia, paroxysmal tachycardia. Now, another thing, when you do have this extra bit formation, you should look at where this bit was originated from. If it's coming out from the sinus, this is called nomotopic impulse formation, such as sinus bradycardia, sinus tachycardia, sinus premature bit, sinus, for example, arrest, anything can be. Or not from the sinus, it can come from anywhere. Can come from the atrium or the AV junction or from the ventricle. Doesn't matter. All right. So this is called heterotopic, not from the sinus. As I mentioned, that can be atrial or can be anything else. Now, this is very important because, as you see here, not every area of the heart can cause any kind of arrhythmias. For example, sinus and junction, that's called, they do have a special type of tissue, that's a nodal tissue. They cannot have fibrillation or flutter. So there is no way that somebody will have a sinus flutter or fibrillation or junctional flutter or fibrillation. There is no way. But they can have, very similarly, premature beat can have, let's see, or the lower one, the junction can have escape beat or extra escape rhythm, or proximal tachycardia, premature beat. This is what the junction can have. And however, there is no fibrillation or no flutter. As you see here in nomotopic one, can be tachycardia, can be bradycardia, can be, as I mentioned, that sinus premature bit, or can be arrhythmia, such as a respiratory arrhythmia or sick sinus syndrome. And this is what it can happen. If you look at the muscle type area, such as the atrium or the ventricle, in addition to this one, we can have flutter and fibrillation. Of course, in the atrium, we don't have, let's say, escape rhythm because that's a nodal tissue. However, in the ventricle, we still have some nodal tissues, and that can, let's say, cause escape bit or escape rhythm. So this is what we have to differentiate. Okay, let's see. Sinus premature bit, basically meaning that you do have an early coming bit and the morphology of the P wave within one lead identical to the sinus bit. Fine, that's period we can figure out easily. Sinus tachycardia, very simple. We always have, let's see, P wave in front of the QRSs. However, the rate of the P and the QRS is higher than 100 per minute, such as here, for example. Good, let's go on. Sinus arrest means that in one point, the sinus doesn't fire. This is not a conduction abnormality. This is an impulse formation abnormality. The sinus does not fire. So here in the gap, we do have twice as long interval than in the normally. Now, what is the problem with this one? The problem that, for example, when we had a rate of 60, for example, here the rate is dropped down to 30. And if you do have 30, there is a chance that the lower center, for example, the junction, will hit because the own rate of the junction is 40 to 60. So there is a chance that is waking up. And in this period, you won't have the twice as long P as you expecting when we do have a sinus arrest. We will have a junctional escape bit, for example. Okay, sinus bradycardia, very similar to the tachycardia, except we do have less rate, but always we do have P, QRS rhythmically, and every QRS is preceded with a P wave, such as this one. Okay, sinus arrhythmia. Sinus arrhythmia, there are two forms, basically the respiratory arrhythmia and non-respiratory arrhythmia, such as in elderly patients when they do have a problem with the sinus activity. Respiratory sinus arrhythmia, or called the breathing arrhythmia, everybody will have it, and you can try it when you feel your pulse and, let's see, inspire the air and expire expiration, and you will see that it's fasting and slowing down the heart rate rhythmically. So what you do see on the ECG, that sometimes you have a longer interval, shorter interval, longer interval. So by the rate of the respiration, you do have an additional repeated sequence. Now, sixth sinus syndrome, well, usually is elderly when we do have arrhythmia absoluta, and we do have sometimes more, sometimes less P wave, but we always have sinus P wave. So it means that the impulse is generated in the sinus node, however, randomly. Okay, premature atria.
Can I have a
Yes,
question?
yes.
So what's the difference between the sixth sinus syndrome and the sinus arrest?
Okay. Basically, the sixth sinus syndrome include the sinus arrest as well, because sometimes the sinus doesn't fire. Sometimes the sinus fires, let's say, faster, and they included in sixth sinus syndrome. When we talk about only sinus arrest, we're talking about only one revolution. It's not rhythmically coming back, the sinus arrest. If somebody has a sinus arrest, only one way, or maybe more than only one way to survive it as an escape rhythm, so the lower center will fire. Okay? Understandable?
Yes, thank you. Yes, thank you.
Okay. Now, atrial premature bit, very similarly to, as I mentioned, to the sinus premature bit, except the P is different from the sinus P wave. So when you looking at, for example, that's a normal, when you're looking at, you do see a P wave in front of the QRS, but that P is not the same as a sinus P wave. Immediately you can say that, yeah, that's a, let's see, atrial premature bit. Now, this premature bit can be originated from one area of the atrium. That's okay, because this way the oxygenation abnormality is not too big problem. However, it can come from more than only one foci. So if you're looking at, for example, these extra premature bits, if the morphology of the P in these premature bits are different from each other, you can say that the multifocal premature atrial contraction. All right. If you do have only one type of extra P wave, that's a monofocal one or unifocal. If you have more, that's called multifocal. Okay. For example, atrial premature bit. Here, if you look at, for example, this is sinus, this is not sinus. Now, the best one here, go and compare the P wave in all leads. And here in AVL, you can see very nicely that this P is completely different from the sinus P wave. Yes? Here, here you can see as well, but not as much, the difference is not as much as here in AVL. Again, let's move on. And you do see here, very similarly, this is another atrial premature bit, but this is not a normal sinus as you, but there are different P's in front of the QRSs. So you can say that's a multifocal atrial premature bits. That's it. Okay, good. Wandering pacemaker, well, it's wandering from the sinus to the AV and coming back and forth. Exactly, we don't know what the mechanism for this one. You won't see this kind of wandering pacemaker, believe me. Now, paroxysmal atrial tachycardia, however, we will see, meaning that suddenly starting, and we do have a P wave in front of the QRS complexes, and we do have a narrow QRSs. This is how we know that that's a paroxysmal atrial tachycardia. So it has to be more than 3 bits in a row in the subsequently. Okay. Now, there's another possibility that not only one foci, but more, not focus, one more foci can, let's say, cause this premature bit formation, and that's be a multifocal atrial tachycardia, or MAT, when relatively we do have arrhythmia absoluta with P waves. We do have P waves, but these P waves are different. So far we have two possibilities: arrhythmia absoluta with sinus P wave, that means sixth sinus syndrome. Arrhythmia absoluta with different P wave means multifocal atrial tachycardia. If you look at the simple atrial tachycardia, this is rhythmic. This is rhythmic. The multifocal is not rhythmic because the impulse is formed in different areas of the atrium, such as this one, for example. Okay, atrial flutter. What I said, increases the rate, increasing the atrial rate, and you do have these sound waves. And normally it's every fourth one, every third one, every second one, bit is conducted to the ventricle because we have a, let's see, the AV conduction problem. Now the AV cannot conduct every kind of high rate. During the, let's see, the evolution, this was developed, and this way they save somehow the life of the animals or the man. And this is why that can be with a normal rhythm, for example. All right. But what you do see, if you look at the rate of these sound waves, you do see this less than 300. Okay, very nicely. For example, this is a sound wave. If you do see this kind of waves, this is not a sinus P wave. This is the flutter wave. So this is an atrial flutter. Okay, good. What about fibrillation? Fibrillation, when multifocally the impulse is formed and the heart is, the atrium is shivering, what you do see that some kind of nose waves of fibrillatory waves that you do see, and randomly conducted through the AV. And this is why we do have arrhythmia absoluta and there is no P wave. Sometimes the baseline is a straight line because they're applying a high pass filter and is filtering out not only the noise that coming out from the outlet, but it, for example, some other high frequency noise is cancelled. And this is why you don't see these fibrillatory waves. So never look at or search for these fibrillatory waves. Always irregular, absolute arrhythmia, no P wave, enough to diagnose atrial fibrillation. Does not matter how wide the QRS is. If you have arrhythmia absoluta, there is no P wave, immediately you can say that's atrial fibrillation. Now, if you do have P waves or some small P waves, and if you do see that the distance between these two P waves is faster than 300, again, you can say that's an atrial fibrillation. You will see arrhythmia and very fast atrial impulse formation. This is why you can see atrial fibrillation. Such as this one, arrhythmia absoluta, fine, fibrillatory waves, okay? Best one to look at in V1 because that's very close to the atrium. Now, the junction. In the junction, when the impulse is formed, when anything is formed, the impulse can propagate backward to the atrium or forward to the ventricle. And based on this one, the position of the P wave, of course, is opposite because they're going backward, not in the regularly right to left, but it be the right to the left one. So not to the right to left, left to right. Yes, so exactly the opposite one. Meaning that if you look at lead number 2, for example, you do see negative P waves, okay? However, depending on which portion was activated first. If the atrium activated first and later on the ventricle, first you have the P wave and later on the QRS. If the QRS of the ventricle activated first and later on the atrium, this negative P located behind of the QRS complex. In lead number 2, of course, in lead number 3, exactly the opposite, because normally the sinus gives you a negative P wave. Here you do have a positive one if you have a AVR, okay? Now, if these two compartments, the atrium and the ventricle, activated simultaneously, you don't see any P because the P is located inside the QRS complex. Okay. Now, again, we can have premature bit, paroxysmal tachycardia, escape bit, escape rhythm, and junctional acceleration. Let's see. This is, as you see here, normal, normal, normal. This is coming earlier, followed by a compensatory pause, and we do have a negative P wave, so the junctional P wave, and every fourth bit is a junctional premature bit. This is why I said junctional quadrigemini. What is the escape rhythm? When somehow is not conducted the charge or the sinus doesn't want to fire, there is no P wave at all, it means the sinus doesn't fire. Or we do have a third-degree AV block. We do have a P wave, but P is independent from the QRS. And first, the AV junction is taking over, and with a slower rate between 40 to 60, it will fire. QRS be narrow, T is positive. This is how you know that that's a junctional escape rhythm. Okay, paroxysmal junctional tachycardia. Paroxysmal junctional tachycardia relatively is a very common supraventricular tachycardias. And in this case, the patient will know that applying some Valsalva maneuver or carotis massage, it will stop because this re-entry circle is developed between the ventricle and the atrium or inside the AV. And you can have narrow QRSs. Sometimes you do see this negative P wave, and that's be tachycardic, for example. There are two types of this oh no, it's the junction acceleration we will talk about later. That can be the either nodal tachycardia or non-paroxysmal AV junction tachycardia. When we do have, let's see, a faster rate than a normal one, but it's faster than a junctional own rate. So it can be 90 or 100, and that can be either nodal tachycardia or junctional acceleration. The pathomechanism is different from the paroxysmal tachycardia. Usually is a increase automacy of the junction. Oh, good. All right. The ventricle, very easy to recognize it because the ventricle beat, meaning that the impulse form in the ventricle, but it's never activated through the normal conducting system. If something is originated from the ventricle, it cannot enter back to the bundles. So this way, muscle to muscle activation taking place, so the QRS be wider one, and very important, the repolarization exactly the same, but however different charges is be opposite. So when you do have a positive very wide R wave and a negative T waves, that could mean that's a ventricle repolarization or ventricle premature bit. If you have a negativity after a positivity, that again, that's a ventricle premature bit. I will show you. And similarly to the atrial one, as you see here, now there is no P wave, but you do have a very wide QRS complex with a negative T wave. This is how we have a ventricle premature bit. In this case, maybe that's a trigemini that we have. It can be unifocal, as you see here, because identical the shape. However, when you do have different premature ventricular bits and the morphology different one, that can be the multifocal premature bit. That's bigemini. Yes, you already got the gemini. These are couplets or triplets. And you can have paroxysmal ventricular tachycardia when you do have a very highly increased, let's see, rate. This is around 140 to 200. And you see had a very wide QRS complexes. You still have some notion that that's a R wave, that's a T wave. So this is how you can say that's a ventricular tachycardia. If you have no idea what I show you here, for example, because looks like as a sinus wave, that's a flutter, it's very fast, it can be up to 350. That's another way. Now we can have very similar to either ventricular tachycardia. You do have a ventricular rhythm that is faster than in own rhythm. The rate is usually 70 or 80, but it's originated from the ventricle. Okay, ventricular fibrillation, no cardiac output, and as you see here, this is a flutter and goes to the completely irregular electrical activation. And after the isoelectric line, this is how it's coming up with the fibrillation. Okay, now dorsal the point tachycardia, it's a very important one because that can lead to ventricular fibrillation. This looks like that a ventricle, the axis of changing bit to bit, and it has some kind of let's see, this is a sign that is increasing the amplitude and slowing down the amplitude and increasing the amplitude. So regularly changing the amplitude and axis, and that's called the stall side point tachycardia. Usually occurs when the QT interval is long one, and we do have a placed premature ventricular beats there, and that can initiate this kind of phenomenon. I don't want to talk about the parasystolia. Look at the parasystolia. Okay. All right. So that was a little refresh of the videos that you looked at. Okay. And now we can look at those tracings that you had to do at home. Okay. And I looking at the tracings official. Somebody asked me about the tracing that can be downloaded and they could not edit it because somebody couldn't edit it. Is she here? Looks like she is not. Okay. All right. So let's see the tracing. And I know I do need who has this homework. Okay. And I think that's a homework. This would be the second homework. But now the names are different one, I think. So this is why I don't know who is here right now. So please, who is the first one in this row? Who is here? Guys, wake up.
Looks like she's moved to the other group.
Yeah, but who is the first who can present the tracing?
I think it's me.
Okay, let's see. How do you pronounce Suho or Siho? Sihu? Suho? Sao?
Somehow.
Okay, Sao. Okay, that's be the first one, 103. Maybe who is going to share? Let's see the screen. I share the screen.
Yes, please. Could you share the screen, please?
Okay, I'm going to share the screen. So information abnormalities. Okay, I will share it. Okay, let's see. I'm going to share which wait a minute. This oops. Almost. Okay. Okay. Yep. All right. Good. All right. I'm going to share it. Yes. And let's share this one. Can you see it? And what was the number on it? 103?
Yes. 103.
Okay, 103. All right. Okay. Now I'm listening. Let's see, 103.
After looking at the lectures, I thought this was a bit tricky because I could see regular rhythm.
Okay, so the rhythm is regular one. Okay, what about the rate?
And the heart rate was a bit less than 3 squares, so it would be a little bit over 100 beats per minute.
You can say it is 120, so that means tachycardic. Okay.
Right. So because it has regular rhythm but has a heart rate over 100, it would be sinus tachycardia.
But okay, now that how do you know that it's sinus?
Because it has regular rhythm.
Okay, it has regular rhythm, and you do have a positive T wave in the lead number 2 and in negative in AVR, yes. And this morphology of the P is identical, so you can say that's a sinus tachycardia. That's it. It wasn't so difficult. Okay. All right. Now let's see. Okay, who is the next one? Let's see. I'm okay. Jang Hyun, how do you call it?
Yes, Jonghyun.
Janghyun. Okay, you have 104. Yes, 104. Okay, let's move 104. All right. Again.
So it seems regular and rhythmic,
Okay.
and the heart rate is 7 peaks in 2 minutes, so it's 210 BPM.
Okay, very good. So it's very tachycardic. All right.
Yes, so it's more than 100 BPM, so it's tachycardia.
Okay.
And in lead 2, there is positive P waves.
Okay.
And in the AVR, there is negative P wave.
Okay, that's a
So-
T wave, so it looks like you don't have any P waves. Maybe we don't know exactly. So there is no P wave, let's see. But that's rhythmic and tachycardic. So
So it's sinus tachycardia.
no. Why?
So it doesn't have P wave.
Okay, no, not exactly. So another thing, you learn in physiology that the impulse in a sinus cannot be infinitive. So it does have a limitation for this rate. What could be the maximum rate of the sinus? How fast the sinus can fire? No?
Is it 4 meter per second?
What?
You are asking for the velocity of firing?
Yes, so let's see the maximum rate of the sinus.
4 millimeter per second? No?
No? Anybody can express me, let's see this.
100
Ah,
frequency per minute.
No, 100, more than 100, because we said that 100 can be the, let's see, the lower limit of the tachycardia. But you know that the sinus rate is the maximum sinus rate is depending on the age. So 210 minus the age, this is about the maximum rate that the sinus can fire. For example, in my case, because I'm much older than you are, so I cannot have a rate of 190. But you can have a rate of 180 very easily. And when you exercise, usually an aerobic exercise includes that a certain period of time that you can get about 80% of the maximum or 60% of the maximum rate. So this is sometimes you know that if the rate is faster than, for example, the maximum rate of the sinus, for sure it cannot be a sinus. So for example, here, when you do have a rate of 210 or over 200, immediately you can say that for sure is not a sinus rhythm. If you do see P waves, okay, you can see P waves, but that can be an paroxysmal atrial tachycardia. If you don't see any P wave, you cannot distinguish this P wave, you can say that that's a paroxysmal junctional tachycardia. Okay? Or supraventricular tachycardia, okay? If you don't know junction or not junction. Supraventricular means everything over the ventricle. It can be, let's see, atrial one, can be junctional one, all right? Could you follow me?
Please go over it again.
Which one that I should say it again?
When you're explaining right now about the supraventricular tachycardia.
Okay, supraventricular tachycardia meaning that the impulse or this impulse abnormality is originated from the supraventricular areas. Which are the supraventricular areas? Tell me. You don't know?
Yes, sir.
No, tell me.
the sinus node and
Can be the sinus, can be the atrium, can be the AV junction. Yes. So these are the supraventricular areas. So when we talk about paroxysmal tachycardias, for sure we cannot talk about sinus tachycardias. This is out of the question. We could talk about atrial and junctional one. But if you cannot make any difference between the atrium or the junctional tachycardias, you can say that the supraventricular paroxysmal tachycardia. All right?
Yes, please. I got to know. Thank you.
Oh, all right. Okay. Now let's see the next one, Sarah.
Yes, that's me.
Good. Very good.
I have a question.
Okay.
Yeah, in AVR there is no P wave, right?
Which in this case?
Yeah,
In this case.
Yes.
Yeah, there is no P wave, but none of them we do have P wave because hell knows what kind of wave is this one. Okay, I have no idea whether this is a P. I don't think that is a P wave because it's very far from the QRS complex. I think that's a T wave. And if you come here, this is T wave. That you can see very nicely T wave. So I believe that's a T wave. Again, that's a T. See, this is the T for sure. That's a T wave.
Okay, thank you.
You're welcome. Okay. Now let's see, Sarah.
Thank you. And I have 105.
Yes,
The
you
reading
do.
was regular.
Uh-huh.
The heart rate was around 60 beat per minute,
Okay.
which could be normal or a little bit slow.
Normal.
Okay, normal. No, it's
There is
good.
no little bit, no little bit. I like you or don't like you. If I like
Okay.
you a little bit, never ever you will say hi to me again.
Okay, so 60 is normal. That's really
Okay.
good.
All right.
But I could see a little, I forgot the word, but it's like F wave.
Sow waves or flutter waves.
Yes,
Very
flutter.
nicely, you do see the sow waves, and it looks like regularly conducted. So every fourth one is followed by a QRS complex. So
Yes.
that's a 4-to-1 conduction.
Yes. so
Okay.
it's definitely.
Okay. What about the axis?
I found the equiphasic in second and positive AVL. So I saw its axis around 30 degrees.
Minus 30 degrees. But I would say that this is less than minus 30. So this is placed between minus 60 and minus 30. Because because lead number 2 is negative. All right.
Okay. It's
All
more
right.
like negative. True. Yes.
So that's an extreme left deviation. Later on, when we're discussing the conduction abnormalities, you will have a additional diagnosis, not only the flutter that you can make. Plus, if you do see that this QRS is wider than normal, so I would say that this is wider than 0.1 second. Yes, this is wider. Okay, so again, in the next time, you be so expert on this field because you do see that this patient has conduction abnormality as well. Of course, we do have conduction abnormalities based on the 4-to-1 conduction because that's a junctional, let's see, conduction abnormality, but never ever this kind of rate could be transmitted to the ventricle. Okay. Thanks God.
Thank you.
Okay, you're welcome. All right, Nada. Ali?
I think she just messaged me and she said that like her computer stopped working, so she's gonna use her iPad and she's gonna try to join again.
Okay, when she is here, okay, please let me know. Okay, the next one is Ines, possible.
Laetitia, you can call me Laetitia.
Oh, I cannot understand anything out of this one. I couldn't hear you.
I said, yeah, Laetitia. My name is Laetitia.
Yeah, share. You want to share yours?
No, I will try without sharing.
Okay, meaning that I do have share it, and this is 107. Yes?
Yes.
Can you see it?
Yes, that's it. So I put that the rhythm is irregular.
Very good.
And I don't see any P wave because it seems to be a flutter, atrial flutter.
Very good. Very, very good.
And I don't know, but in the last row, we see it's like 7 to 1 conduction.
Okay, sometimes it was 7 to 1, but sometimes it's faster because maybe 5 to 1. So this kind of conduction on AV block is changing, is alternating. That means this can cause arrhythmia. That could happen. There is no problem with that one because a flutter can be arrhythmic, not only rhythmic. Sometimes 5 to 1, sometimes 8 to 1. So this is why with a high grade AV block that we do have. Very good. What about the axis?
The axis, if I look in lead number 2, I can consider is isophasic.
That isophasic, that I don't think so.
I don't know because I don't really see the P wave. So
no, let's see. Don't look at the P. There's no P wave. Okay, lead number 1. Let's start with whatever we learned. Lead number 1 positive. Yes. EVF. Oh, look at this one. It's almost equiphasic, not?
IVF, yes, it's
Yes. So exactly perpendicular to AVF, and lead number 1 is positive. So the 0.
Okay.
All right.
Okay.
That's simple. This is why always start with 1 AVF. And if it's normal, fine. If it's not, if here, for example, you can state a little bit more positive, maybe 10 degrees, but who cares about it?
But just a minute, when you say it's isophasic in AVF, how can you see it? Because it looked like lead number 2 for me.
That isophasic, that's a positivity. How do you see that? What is the equiphasic one? All right, now I show you. Okay, I draw.
Okay.
I show. Where is the paint? Good, that's a paint. Can you see it? Okay. So when we do see whether it's equiphasic or not, we have to add the positive part and the negative part. So this is a QRS complex. The whole revolution is important. Here, you can count in millimeters how many millimeters you have in a positive range and how many millimeters you have in a negative range. And the sum of this one, this will give you whether it's positive or negative. In this case, that's positive. However, if I do have this one, that's a negative one, yes?
Yes, I see, but I don't see any QRS in the AVF.
Okay, I show you. Okay, if you do have equal, that means equiphasic one. Now, let's go back to that tracing that you said that you don't see any. Oops, wait a minute. I have to find it. Maybe I have to close it. Okay, good. Which one? Possible this one? Yes. Okay. All right. So this is lead number 2.
Yes.
That's a QRS.
Okay.
It's only positive. There's no negativity in the QRS.
Yes. Okay.
All right.
Yes.
So it's positive, but that's close to 0. So this is why we said that's 0. Okay.
Okay.
All right.
Thank you.
And
also, I mean, this when we see flutter, we cannot say bradycardia because
no. Yes, you could. Why not? That's bradycardia.
Okay. So the heart rate is around 45 BPM.
So that's bradycardic. Yes, you can say it because the bradycardia, tachycardia based on the rate of the ventricular rate. All right. So that it's completely independent where the impulse is formed and what kind of conduction abnormality or impulse formation we have. Only it's meaning that similarly to the pulse, you are looking at the pulse and you know that what the ventricular rate is, and that's the heart rate.
Okay, thank you.
Okay. Nadia came back? No, nobody said. Afaf, I don't know how do you pronounce this name. Afaf?
Yes, Afaf.
Afaf, very nice name. Okay, you have
Thank you.
108. Yes, 108.
Yes.
Ooh. Very nice. No, tell me.
So it's irregular. The heart rate is 160 beats per minute.
160, okay, well, all right.
Around.
Around,
Uh,
okay.
I
It's
think that
tachycardic
the
for sure.
axis is close. Yes, it's close to zero, the axis.
Okay, well, look at lead number 1, positive. AVF is positive.
Positive.
All right, so I don't think that is close to zero. Which one is equiphasic? I would say AVL, see?
Okay.
All right, now AVL is perpendicular to lead number 2, yes?
Mhm.
So I would say that's around 60 or maybe 30 or something like that, okay? So somewhere here.
Okay.
Okay, go on.
Now I think I can see P waves, but they look weird and not
Okay,
the
very
same.
good, very good, very good. But is it arrhythmic? Is it arrhythmic?
No.
Is it? This is not arrhythmic. Look at this.
It is arrhythmic, sorry.
It's very much arrhythmic. Okay, very nice. Okay, but let's look at. Okay, let's look at, because you said that, yeah, you could see some P wave. Okay, yes, it looks like there are some P waves. Yes, here, for example. What is the
Yes.
rate of this atrial rate? Less than 1 big square, meaning that is more than 300. And what did we say about if you do have an atrial rate is more than 300? Atrial fibrillation.
Relation.
Okay, so if you do not see P wave, that's okay. At arrhythmia absoluta, no P wave, atrial fibrillation. If you do see fibrillatory waves, okay, you can see, and arrhythmia, you can see atrial fibrillation. And if you do see some kind of P wave, but not every P the same, so it's changing, but the rate is faster than 300, you can say that atrial fibrillation. So the most important, arrhythmia absoluta, all right? And no P wave or very fast P wave. Capish?
Yes.
Could you
Good.
explain how can we calculate the atrial rate?
Very similarly to the ventricular rate. How did you calculate the ventricular rate? You said that divided the 300 by the number of the squares that we do have between R waves. Here, very similarly, look at these P waves and you have to multiply with this the 300. But very similarly, if you had a P wave that's exactly placed in one square, big square, that means 300. If it's less than one big square, means more than 300. That's it. So if you do have this P less than one square, okay, you can say that that's an atrial fibrillation. Okay.
Okay, thank you.
You're welcome.
I thought it's like multifocal atrial tachycardia. Can you like explain?
Okay. Multifocal atrial tachycardia, that can be similar to this one. So can say that, yes, that looks like we do have a complete arrhythmia, but every QRS complex is initiated with a P wave. However, this P is not the same. Okay, for example, here, okay, you can say that, oh, yeah, that's P is initiating this QRS complex, but you do have much more P waves here. This is why it's atrial fibrillation. If you have a multifocal one, you had only one P wave and QRS complex, one P wave and QRS complex. However, these P's won't be the same. But here you have more than only one piece, yes?
Yes, thank you.
Okay. Good. All right. Let's see. The next one is Homa.
Yeah, so mine is 121.
This is, yes?
I like for my number, it was 121.
121. So this is not that one that you'd have, yes?
No, like on the email you said to go over 121.
Oh, yeah. 121.
Yeah.
Doesn't matter.
Oh,
You
okay.
can have 121.
Okay.
Wow, wow, wow. Okay. It's yours.
Okay. I think so. It's irregular ventricular activity. So I think it's ventricular fibrillation.
Nope, nope, nope,
No?
nope, nope, nope. If you
No.
had
Okay.
ventricular fibrillation, that could be bizarre QRS complexes. It looks
Oh.
like that they are shivering or something. This more likes as a sinus rhythm, sinus waves, and the amplitude doesn't change. When you do have a ventricular fibrillation, the changing, let's see this amplitude as well and the time. These are looks like regular, so these are flutter, ventricular flutter.
Oh, ventricular flutter.
And of course, you
Okay.
can count the rate is around 300, as you see
100, yeah.
here. And that's it. The axis, impossible to diagnose the
yeah.
axis.
Yeah.
Okay.
Mhm.
Okay, good. That was an easy one.
Yeah.
Lina. Lina is here? No? Okay. Who? Jonglei? Lee Jonglei? No?
Yeah, I'm here. Wait, what?
Okay, finally.
Wait.
What is your number?
I didn't get the mail, actually.
Oh, you didn't get the mail. See? But now you filled up. Possible.
Yeah, I filled it up. Yeah.
Good. So the next time you will have it. All right. So maybe I can give you one. All right. And let's try to interpret it. Okay. I can go back. Okay. I can go back. Maybe I give you a very difficult one. Huh? What did you say about it?
I'll try, maybe.
Not maybe. No, let's see this.
Okay.
Anybody has this 116? No. Okay, it's yours. No?
Oh.
Sorry.
Yes?
It's mine.
Okay, don't give. No way that I'm giving to him. Okay, no way.
Can we just do 109?
Yes. I'm going back 109. Why not? Yes, he can do it. Okay, it's yours.
Okay. First sight, I can see it is arrhythmia.
Okay.
Because the
Good.
heart rate is kind of like different.
Okay, so?
And for the axis?
The rate, please, the rate. What is the rate? Heart
rate.
Yes,
Okay.
the heart rate.
It seems like around 60, but
yeah,
really.
That's around normal.
Yeah.
Sometimes it's faster, sometimes it's slower, but around 60. That's okay. I accept it. Okay, go on.
And
now the
I
axis.
cannot. Now the axis. Okay. The both one are positive. So.
Which is both positive? What do you think?
Lead
number.
AVL.
Lead number 1 and AVF. Lead number 1 is positive, AVF is negative. What does it mean?
It is 0 degrees.
This is not normal, it's not normal, all right? You are located in the upper left quadrant, okay? Look at lead number 2. Lead number 2 is
very weird. We can see
very weird. About equiphasic, not the positivity and negativity about the same. Yes?
Yeah.
So this is meaning that you are perpendicular to lead number 2, and that's minus 30. Okay, that's minus 30. All right. So you have to watch the all videos that we had so far. It's very easy to find it. I'm going to send a letter with a new one, but with the previous one, you can find it because under my list, let's say YouTube list or video list, you can go back and forth. And additional information on that one, I will show later that if you, okay, let's, I'm going here. I'm sorry. Okay. All right. Okay. All right. Almost. Don't give up. Don't give up. Okay. Now I'm stop sharing it and I'm going to share this. Okay, so if you go there, you will see this is the teaching material. Okay, teaching material. And here you do see the list of all teaching material. You will find it. Okay, so from the fundamental till the end of the conduction, that's before the next week. And if you go to the first part of the session, for example, if I'm going to the the first of the fundamentals, you will see this is the hard copy that you can download it from. Okay?
Okay.
In the impulse formation, the first one will contain, okay, that's the fourth one. Okay, that's the fourth one. That's the second one. No. You will find it. That's it. This is the arrhythmias, see, impulse formation, and here you can find it. So in the first video, you will find always the copy. Okay, let's continue. Let's continue. All right. No, continue. What about the impulse formation? Where the impulse is formed?
Where the impulse is formed?
Mm-hmm.
I'm not really sure about it.
Oh, okay. Arrhythmia absoluta. There is no P wave. So what is your diagnosis?
There's no P wave. Yeah.
Atrial fibrillation. Arrhythmia, no P wave, atrial fibrillation immediately. Okay.
Okay.
All right. Next one is J. Kyung. Ji Kyung. I don't know how do you pronounce it.
That's me.
How do you pronounce your name?
Jaekyung.
Jacka. Okay.
Jaekyung.
Jagga.
You can call me Jackie.
Jackie, that's good. Jackie. Okay, Jackie. Which one that you had? What was the number on it?
111.
111. This is yours.
Yes.
Wow, that's an interesting, a tricky ECG. Very tricky.
Oh.
Oh, you didn't know that.
I think it's first of all, the pulse is regular. So it's about 60 BPM.
Okay, good.
And I saw there's no P wave.
Okay.
So I guess it is junctional escape rhythm.
Okay, very good. Very good. Very good.
And for the axis.
Okay.
The first lead and the AVF shows positive. And I saw the third one is the equiphasic one. So we can say it's about 30 degree, but it is more positive to second one than first one. So I think it's 30 to 60 degree.
Okay, 30 to 60 degree. All right. Okay. Good. Very good. Go on. Yes.
QRS is quite normal. And the P wave will be simultaneously, P wave is in the QRS complex. So because there's a simultaneous activation between the atrium and ventricle.
Okay, let's look at this one. Let's look at this. In lead number 3, you do see there's some kind of waves here, and the rate is very fast, is more than 300. So this is why it's tricky one, because you do have an atrial fibrillation. However, it's rhythmic because you have a junctional escape rhythm. So you have a third degree AV block with a junctional rhythm and atrial fibrillation. This is why I said it's a tricky one.
Okay.
So if you do see some kind of wave or atrial rate that is very fast, you can say that's an atrial fibrillation. But this atrial fibrillation is not influencing the ventricle because it has a block. This is what we learn in the next time. And taking over the junction. So we do have still a lower center that can fire. So we do have a junctional escape rhythm. Very good. Very good.
Thank you.
Alice. Leroy Alice is here.
Yes.
Okay, you have 126, yes?
I didn't see that email, but okay.
Yeah, this is why, because your email wasn't perfectly set up. Okay, 126, 126. Hopefully by the next time you will receive your email because you filled up the email, yes?
Yes, I filled it up.
Good. Now let's see this. It's very simple one if you look at it immediately.
Yeah, there is a lot of tremulation. No.
Huh? It's not rhythmic for sure. Okay.
Yes. It looked like atrial flutter.
Nope, 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 nope. That's okay. That looks like as a sinus rhythm, but here something starting. Something starting is right here. So. Oops, I'm sorry.
This is ventricular flutter.
No. Nope, nope, nope. Nope, 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 nope. You see some kind of spindle or spool formation is here, see?
Mm-hmm.
This is the torsal the point tachycardia. This is what was the last one that I discussed with you. That looks like is a ventricle rhythm. You can see that's a ventricle rhythm, but the amplitude is not the same, it's changing. And this is why we said that's a torsal the point tachycardia.
Okay.
Okay. Good. All right, let's see the next one.
Sorry, excuse me. What is the answer?
Yes.
I just can't hear you well. What is the answer for this?
That's a torsal the point tachycardia. Torsal the point tachycardia.
Thank you.
Torsal the point tachycardia. Okay. Sanju?
Yes.
Okay, 122, yes?
Yes, correct.
Okay, 120. Ah, immediately you can say it.
Okay, so it's irregular. And we can see it's a ventricular fibrillation.
Good, that's it.
Yes.
Ventricular fibrillation. Ventricular fibrillation. If I'm asking you what could be the pulse rate of the patient, what would you say? That's a tricky question.
Pulse rate, like heart rate?
Pulse rate, pulse, when you feel the pulse of the patient.
More than 450.
Anybody?
0.
Yes, because the cardiac output is 0. There is no blood pushed into systemic circulation, so 0. All right, so don't take this trick. I'm a tricky guy.
Okay.
Okay, Mickey.
Can I ask one question?
Yes, ask it.
Yeah. So when we see 122, you can see kind of change of amplitude during the
but
ECG.
this is,
so it's not anything about it.
No, that's atrial. This is why you said it's a ventricular fibrillation, because the amplitude and the rate is varies. It looks like there's a multifocal ventricle impulse formation is going on.
Okay.
All right, Mickey.
Yes.
Okay, 116. Yes.
Yes.
The easiest one to remember, Mickey, because my nickname is Mickey as well. Okay.
Okay, yeah, I'm ready. Yes. Okay, this is arrhythmia. It's because this heart rate is 40
Okay.
beat per minute.
Okay, good.
And then when I look at read one, it is like negative.
Very good.
And so it means there is left deviation.
But right deviation,
Oh,
yes.
yeah, sorry, yes.
Right deviation.
Yes,
Okay.
yes.
Okay.
Right deviation. And then when I check the AVR lead, and it shows negativity. So like it's a right deviation, the range between 90 to 120. But like
Good.
when I compare the read 3 and read, wait. Just a moment. Yes, when I compare the read 3, number 3, and the AVF, read 3 shows like has a bigger signal, so it is close to like 120.
Okay, so you can have an extreme right deviation. All right, go on.
And then I would say it is ventricular premature contractions.
It cannot be premature one because you do have at least 3 or 4. So that's written. That's written.
But like, I have a question, because like in your slide says if there is T wave, like inverted T wave, and if the QRS length is over 0.12 second, it'll be the like ventricular premature contraction.
Yeah, but only one bit that you are talking about premature contraction, but this is not premature contraction because you do have at least 1, 2, 3, 4, so continuously coming, so it has to be a rhythm. Ventricular escape rhythm. Okay, so that's we do have a 3rd degree AV block. We do have P waves. Yes, you do have P waves. We do have a sinus bradycardia in the atrium, but none of the beat is conducted through the ventricle, and you do have a ventricle escape rhythm.
Sorry, could you repeat it again? Because like there is Wi-Fi network, so I can't.
Okay, all right. So we do have P waves. Can you see the P waves right here? Okay.
Yes, I can.
Okay, so we do have P waves, and the rate is 1, 2, 3, 4, 5, 60. So we do have a rate of the atrium of 60. However, none of the P is conducted to the ventricle. This is why we have a 3rd degree AV block. This is the next time. And we do have a wide QRS with an inverted T wave. So we do have a ventricular beats. Okay, we have several ventricular beats. It looks like the ventricle leads the charge. So it means that's a ventricle escape rhythm. Okay?
Yeah, thank you so much.
Good.
I'm sorry, I didn't get that. How can you tell it's not a premature?
It's not a premature because a premature, what does premature mean? Comes earlier. Comes earlier.
Yes.
This is not coming earlier. It's less than 60. So it cannot be premature beat. It cannot be tachycardia. It has to be some kind of passive arrhythmia. So this beat is much slower than a sinus beat. So this is, and you know that this is coming from a lower center. So when you want to say that whether is it sinus? No. It's a junctional? No. It's a ventricle? Yes. So these are the different, let's see, location of the nodal tissues. This is how it can fire. A premature beat. One premature beat means that comes earlier. You can point that this is a little bit shorter area. There's a tachycardia. So premature beat always speeds the heart rate up. So it's always an active arrhythmia. And this is not active arrhythmia. That's a passive arrhythmia. You have a slow rate. Yes?
Yes, yes, it is. Okay, thank you. I got it.
Good. Mao?
Yes.
Okay.
Can you hear me?
118, yes?
Yes.
Okay, it's yours.
So for 118,
Okay.
the rhythm is not regular.
Okay.
And for the axis, lead one has positive. So I checked AVF and it was positive. So it's within the normal range. And lead one has highest amplitude. So it could be like 0 to 30 degrees.
Very good, very good, very good. So lead number 3 almost the same. So it's about 30, but closer to 1. So between 0 and 30. Good, go on. Impulse.
And impulse. So 4 hour waves were within 6 seconds. So 40 BPM.
Okay, very slow, very slow. But why do we have this arrhythmia?
Maybe sinus arrest.
Yes, congratulations. Yes, that's sinus arrest because there is no P wave, no sinus here as well. And another, yes, we do have P waves and sinus. So sometimes there is no P, not at all, straight line. That's sinus arrest. Congratulations. Good.
Thank you.
Very good. Okay, Harunoshuki.
Yes, it's me.
Okay, good. Harunoshuki. Did I pronounce the right way? No. Okay, it's yours.
Yes. And the rhythm is, it's regular.
Irregular.
Yeah.
Irregular. It's not regular, it's irregular because they are not the same, okay?
And the heart rate is around 180.
Okay. 180, all right.
And the axis?
Yes.
The lead one is positive and AVF is slightly negative, but it's
okay. Good, good, good. Okay, slightly negative, but it's close to equiphasic. Okay.
Physics, so the axis is gonna be close to 0.
0, yes, between 0 and minus 30. So it's a left deviation. All right. Now, impulse formation. Maybe I magnified. No, I cannot. Can you see it?
Yes.
Okay, so what does it mean? Yes, maybe this one. No, it's not that one. Oh, no. Okay. Oh. Look at the P waves. There are P waves in front of the QRSs. However, they are not the same. So, what does it mean? Anybody? Arrhythmia absoluta with different P waves. That's called multifocal atrial tachycardia. Yes? If I say yes. Okay, so when you have arrhythmia and tachycardia, fine, and you do have P waves. However, these P waves not the same. You know that the impulse form an atrium and from different area of the atrium. This is why you say that's a multifocal, and because atrial and because tachycardia. Okay.
Yes. Okay, thank you.
You're welcome, guys. Okay, I think that's the end. And hopefully I do have every email, and relatively this email will go through. So I will send you the new, let's see, homework and the new, let's see, videos that you should watch. Okay. So we will see each other. So everybody filled up this, let's see, table.